So, very good morning. Uh, I don't need to really introduce myself. I'm a part of the International Implant Masters Academy Mentors Group. I'm a prosthodontist by profession and a certified implantologist. Um, Part of my life, a chunk of my life went in doing conventional implantology. I still practice that. But the later part of my life right now, cortical implantology is what I extensively practice. So the other day, in one of the doctor's clinic, when I went in, the patient was discussed about implants, and he had come down from Haryana, and they had got cortical implants placed in, and they wanted to change the prosthesis, and some implants had failed, and there were a lot of issues we were dealing. So while doing that, at one step, he said, when I told him, we will finish the work in 3 days and everything will done. Okay. So he asked, sir, डॉक्टर साहब आप ये वर्कशॉप में ही करोगे ना? I literally had to plead in front of him, say that please give me some uh, level of what do you say? Don't insult me really. This is a clinic, not a workshop. But then yesterday, when I was sitting and working on this particular program today, I realized that uh, the difference, there's practically no difference between a workshop, a car workshop, and dental setups. Um, we, if you look when the car comes in and has got difficulties and issues, the craftsman or the technician will first diagnose the condition, whatever we are. He'll take a test drive, he'll see everything, and then he'll come up with a thing. And then inside the workshop, a well arranged workshop, he will be able to correct, and he will be able to modify, and he will be able to solve the problems. So yeah, definitely it was a crude way of communicating, but our clinics are nothing less than workshops only, except that we are dealing with human beings. I think that much respect our patients have for us. So having said that, very good, if you walk into a workshop, the one, if you want your work to be very good and meticulously done and all your problems are solved, one of the most important aspects is that how well and how ergonomically your instruments are arranged, and how well your diagnosis of a particular problem is done. A lot is a lot is emphasized on the aspects of surgery, aspects of prosthetics and everything. Agree, they take a major chunk, but a small percentage also is there should be a focus on some important aspects of of the treatment option, that is the diagnosis, as well as how ergonomic and how well we are able to perform the procedures. So the topic for today's presentation works on investigations and the armamentarium in cortico-basal implantology, and this plays a vital role in doing it, because we as clinicians, when we are working on patients, we do not like suddenly issues coming up. Suddenly, this, we come with a mental frame of mind and a thought process. This is how we are going to execute the entire surgical procedure or the prosthetic. And no one likes to get sudden challenges while working or operating. And second is, no clinician would want to do a procedure with a deficient armamentarium. So it's always a little dry area because it is not focused a lot while we are in the teaching training programs. So Dr. Ashish spent a little time and said, we will focus on this and we'll give a good amount of time to understand this particular thing. So having said that, in general dentistry, as well as in implant dentistry, we have a very good amount of instrumentation, huge amount of instrumentations, which we purchase and we keep in our clinics, and we maintain the records, we maintain the entire library of all these instruments and equipment so that when the patients walk in, we are able to treat them immediately and we are able to provide the best quality of treatment. Now that there is a paradigm shift from conventional to cortical implantology. Cortical implantology is just not a patient walks in and you have whatever instruments you have, you go ahead and do it and randomly work. It also requires meticulous planning, and it requires a very thoughtful process, keeping the end in mind while we execute the entire treatment plan for the patient. So, in this particular treatment plan, to reach a plan, we need to collect data from the patient. We need to analyze this particular data, come to a conclusive diagnosis, explain the diagnosis to the patient. Once the patient understands what the patient is actually suffering from and what is how to treat this, then we execute the the surgical aspect of the treatment plan, and then the prosthetic aspect of the treatment plan, thereby providing the entire treatment for the patient. And I think Anand sir will agree with whatever I'm saying, and Dr. Ashish also. So within this data collection, photographs, x-rays, investigations, and a thorough medical record and a history taking is important. One aspect of this is investigations. See, our naked eye will observe in the patient's mouth certain aspects, but our mind is not really a supercomputer as the world thinks it is. It will register certain things, not more than 15% of what they have seen within a span of, let's say, 1 to 2 minutes. In order to enhance whatever we have seen and remember, we have photography, we have collection of diagnostic casts and models. Along with that, the history taking is also done. Now, patient will give history, and during my young age, I used to watch a series called as Dr. House, and his famous statement he used to make, the character used to make, is that never trust your patients; they always lie for their vested interests. So, whatever history we have collected and whatever history patient has not given to us, or the history the patient is unaware of, these investigations will help us. So, whenever a patient walks into my practice and I advise the patient for certain investigation, the patient will say, "Why do you require an investigation? You just have to do the work and go." No, I said, really sorry. I'm definitely dealing with a human being and not with a innate non-living object. In fact, even when we take our car into a garage, today's world, they investigate using some chips and some plug-in USBs, which they will plug into our computer. They plug in into a computer. They record the entire data from our cars, and then they analyze the data to come to a conclusion what will be the probable issues associated with that. That is the diagnostic running. Our phones have got diagnostic setups which we can self-run the setups to understand that what are the issues associated with our hardware as well as software issues. So if our phones, our electrical equipment, our cars, everything around us has got investigations done, of course the human body requires also that, because I can only see from my eyes 10% of that particular oral cavity. I do not know inside how the blood is working. I do not know how the bone is inside. What is the shape of the bone? What is the pathology inside? Because that is invisible for me. I don't have x-rays. So investigations play a major role, and our patients should be aware. And if they're not aware and they're in ignorant about this particular aspect. We need to educate them. Of course, they're laymen, they're not dentists, they are not people with a very high level of IQ, which doctors have as compared to the general public. So we need to make them aware of why we require that. For that, we ourselves should know what investigations we need to order and which investigation we need to order for what aspect. So for that, the first aspect would be the diagnostic imaging for dental implants. Though we have various types of imaging modalities, periapical radiography, panoramic radiography, occlusal radiography, cephalometrics, tomographic, that is CTs, CBCTs, MRIs, all these are there. But three important radiographic modalities are expected for us to understand, read, and advise also in dental implants. One is the periapical radiography, RVGs and IOPs, which all of us have in our practices. Other than that, panoramic radiography, orthopentomogram, or OPG is another one which is important. And the third, which is CBCTs. So many clinics now are upgrading themselves to have OPGs within their own institute, but RVGs are a must. They always are there in our clinics. OPGs and computed tomographies are where we probably send them to a diagnostic center and get it done. And or if we have a high-end practice, we keep them and we are using them. Uh, but in due course of time, probably almost every clinical setup will have this particular, at least OPGs machines with there, because now they have become economical to purchase and keep. Anywhere between 5 lakhs to 10 lakhs is the amount for OPG machine to be kept in. Now, uh, dental implants, what is important is to understand when an RVG is important, when a OPG, and when a CBCT. Now, doctors when we do our clinical programs and we teach doctors about the skill enhancement in terms of implant dentistry, a lot is focused on OPGs and CBCTs and all. There are some advantages of each of them. So CBCT has a very specific role in our practice as implant dentists. Why? Because they give us we work extensively inside bone, which is practically a blind in procedure for us as compared to doing a cavity preparation or doing an access preparation in a tooth, because you can visualize it with your eyes, you can visualize the canals, you can visualize the orifices, you can visualize the cavities, but bone is something you cannot really visualize. So how three-dimensionally we are able to observe the bone, reconstructed images of the bone on the computer will help us a lot. So the advantage is it gives a three-dimensional image of the maxillofacial area. It gives us a clear visualization of these anatomical structures in and around within the bone, such as nerves, sinuses, adjacent teeth, everything. It allows us to go for a thorough evaluation of the quality as well as the density of the bone, because that is something which is nothing to do with quantity. That quality assessment, arbitrary quality assessment and density in Hounsfield units, which a CBCT will be providing us. And I'm using the word arbitrarily because there is no instrument which we can give us an exact value of the bone other than bone densitometers, but that cannot really give it in the maxillofacial area. So CBCTs are able to provide the Hounsfield units, which is arbitrary, but it is close to exacting. So once we understand the quality and the density of the bone, as implantologists, we will be able to manipulate our methodology, our way in which we are going to approach a particular case. It provides us precise measurements of the height, width, and volume, thereby making sure that we understand that when we enter into the oral cavity, when we enter into and make a puncture hole into the on osteotomy in the bone, we are able to easily differentiate our angles. We are able to understand which area we are entering into, and we are not practically so much blind. So they act as eyes for us, CBCTs. Okay. Um, they also help us in assessing the integrity and the health of the peri-implant structure. That means we place the implants, we load the implants, we do everything. And when we turn back to understand the post-operatively how it is, that also gives us a very good understanding about, so that we improve ourselves every case by case. Every time we move, we improve ourselves. But of course, it also helps in a virtual treatment planning, not much in cortico-basal, but more in the conventional methods. So this is how a reconstructed 3D image is generated, giving us a clear-cut idea of the patient. So even when the patient is not with us, and it is like an X-ray machine in our eyes, which we are observing everything in and out. So when we open up, we are able to understand things. And all the more it is important in the field of cortical implantology, because once we are doing, most of our procedures are flapless in nature. Most of our procedures are done for patients with highly compromised posterior maxilla and mandible, which a high amount of sinus pneumatization, very close to the nerves. We practically every second case of ours is all about bypassing the infraocular nerve. So, having said that, we need to understand the course or the direction or the path of travel of these particular nerves, how close they are to the crest, how far they are, how three-dimensionally they are positioned, so that we are able to well bypass them. We are able to get our implants deep inside cortical bone without injuring any of the adjacent hard and soft tissues present in the system. To an extent, the American College of Prosthodontists have presented a positional statement, and when a very big academic institution puts in a positional statement and publishes it, that means it is like a law. It is not just any other article, it's a law, which is where it talks about diagnostic imaging in treatment planning, surgical and prosthodontic aspects of implant dentistry. And it is a must article to read, because it gives a review of the perennial literature and the guidelines and has been published. So it keeps us medical legally safe. It makes us to understand that what is the importance of each of the diagnostic tools. I have, the recommendations, I have shortened it up, and I have positioned. It's a point to be noted here that conventional panoramic or intraoral periapical imaging is recommended purely for initial diagnostic evaluation. CBCT, on the other hand, is not recommended for routine initial examination. That means that every patient does not need to undergo a CBCT analysis. Only when the patient confirms and is ready for getting an implant treatment done. And when you know that you need to understand the biology of the or the morphology and the structural part of the entire, then you advise a CBCT. We can comfortably work with conventional panoramic and intraoral imaging, that is your RVGs, for our initial diagnostic evaluations. The cross-sectional imaging or CBCTs are preferred over CT due to its significant lower radiation dose, and is recommended for purely preoperative implant assessment. That means when the patient is ready for implant surgery, before the patient is sitting on your table, if we have a CBCT for us, we are able to understand the cross-sectional imaging to give us a better view, and purely for that, as compared to CT, that is a full body CT, because of the amount of radiation dose. And second is the slices. Distance between us, between the slice, that is the slices of the cross-sectional slices, the thickness of the slices is different between CT and CBCT. CBCTs are more refined for as compared. But yes, CT becomes quite mandatory when we start moving from using conventional methods to some more deeper methods of placement of cortical implants. That is, when we are doing zygomatic implants, when we are placing implants in different ethmoidal sinuses and beyond a certain cortical bones present in the maxilla and the mandible, that time CT plays a very crucial role there. So if you're planning to do a zygomatic case, then it would be better other than the CBCT, because CBCT is not able to really identify the zygoma areas correctly. So CT helps us a lot in those particular cases. CBCT imaging should be used for aesthetic zones, pre and post bone grafting, sinus segmentation, of course, pterygoid plate and zygomatic implants. That is basically from the point of view of convention. Whenever we do order a CBCT, if we are doing a small quadrant, if you're doing one or two teeth, always the region of interest ROI should be imaged using a FOV method rather than the entire full arch or the full mouth. So that means if you're doing a full mouth, then you require a full mouth CBCT. If you're doing one arch, then you only advise for that one arch. And when we're doing a small quadrant or one or two teeth, you advise FOV for that particular area only. CBCT is recommended to be used for evaluation of post-operative complications. Of course, if you suddenly you do a good surgical procedure, yet patient comes back with some paresthesia issues or some complicated problems like swelling, pain, discomfort, you would probably go ahead and do a CBCT to evaluate your final positioning of your implant and whether it is interfering with any of the anatomical structures or any type of infections. But the gold standard in cortical is your OPGs. Because if you see the yellow line, you see those red lines marked in the OPGs, that helps us to overall evaluate all the cortical areas of the maxilla and mandible in one two-dimensional view, thereby making us understand what should be the plan for us, not just tentative, the definitive plan of placement of the implants. Second, what are the identification points in our cortical of the cortexes, first, second, and third cortexes within the maxilla as well as in the mandible. Thereby, when we plan, we execute, we are able to understand the difference and we hit the bullseye. So, irrespective of whatever, every case of cortico-basal implant dentistry should have a preoperative OPG and a post-operative OPG for initial and post-operative assessments. Period. There is no second thought about it. Every case, not just from the documentation purpose, but also from the pre and post evaluation purpose. I guess I'm pretty much clear in what I'm saying. But RVGs also play a good role when we are doing cases, but only intraoperative, just to give us that understanding whether we are hitting the nail in the right spot or not. You can see here an extraction, and then post after the pre-operative, and then extract, and then we're placing. We are trying to two-dimensionally and understand, analyze. Of course, our tactile sensations also give us those inputs whether our procedures are in the right place or not. But even after doing this, we still post-operatively should send the patient and get the OPG done. So this is about diagnostic imaging in brief about diagnostic evaluations before and after cortical implant placement. Other than that, blood investigations. Now, this is something which everyone says, yeah, I know it. I order it. But honestly, why we are ordering it, when we are ordering it, we really don't know, or we tend to overlook it. Blood investigations are a very crucial, important aspect of implant dentistry because whether you like it or not, period, that we are doing an invasive procedure. Even if we are not going to give an incision, we are not opening a flap, we are not doing extensive invasive procedures, but implant dentistry is invasive in nature. And when we are doing an invasive procedures, we need to understand the overall biology of the body, plus in and around that area. And blood, it is the life, it provides life to a human body, blood. Okay. And blood investigations play a very important role because it is that blood itself which is going to help it to heal. It is the blood itself which is going to help the system to properly heal, well, not only heal the bone, but also to help it to integrate with the implant. It is the blood and the bone. Blood contains mesenchymal cells, undifferentiated, which in different parts of the body will go and differentiate into specific cells of that particular part and help to regenerate and revive and heal. So a blood investigation plays a very crucial role. What are the blood investigations which we need to order? CBC, complete blood count. BTCT, that is bleeding time and clotting time. PT and APPT, that is prothrombin time and activated partial thromboplastin time. HbA1c, FBS, that is fasting blood sugar, random blood sugar, and postprandial blood sugars. HbS-AG and HIV. These are the basic level of investigations which need to be done. I'm sorry, it is APTT, not APPT. Sorry, it's APTT, thromboplastin time. So first is CBC, complete blood count. Why is it important? Because when we order a CBC, it will measure the RBC count, the RBC level cells. It will measure the WBCs. It will measure the hemoglobin content, the hematocrit value, and the platelets, which will help in blood clotting. So RBCs, we know why are they important. They transport oxygen from the lungs to the rest of the body. So it's very important, the amount of RBCs present. The WBCs are the ones basically the fighters of our body. They're going to help in fighting infections. So we need to clearly understand what is WBC count, because we are doing it invasive. We are putting a foreign body inside the system. So we need to know the infective levels, how immune the patient is and how immunocompromised the patient is. The hemocritic value not only will give us a very detailed analysis of the RBCs, because everything, the oxygen, the lungs may be filled with good amount of oxygen. If the RBCs also may be very good, but if the RBCs are of not a good quality, then still the system will not work. So hematocrit value also is very important. Of course, hemoglobin is nothing but the protein in the RBC is going to carry this oxygen. So this is all important for us. Why? Because the consequences of something going wrong with this has a lot of effect on our system. The repercussions are something which, if left undiagnosed, will puzzle us and we will not realize what actually was the issue. Many times and because see, we are mostly dealing with old patients who are geriatric. And geriatric cases, when they come in, the amount of time to heal, the amount of time to recover, everything is different from the regular individual. More so ever, these CBC is going to tell us whether we are going to be expecting delayed healing, we are going to be expecting differences in density, what is going to be a thing. And we keep thinking and think, why is the system not healing? What's going wrong? What is the issue? Not realizing that these systems were probably impaired in the patient. So if you do not take a CBC, we will not critically realize that. And we are only thinking that probably something is wrong with our way in which we have done the case. Probably it is not us which have gone wrong. It may be probably in the patient's innate system that is not able to take up this particular thing. So it's very important, even pre-operative, to understand that. Imagine most of the patients are anemic. When we see, what would be the repercussions? Delayed healing, decreased bone densities, increased healing time, intraoperative bleeding in patients is high. These are certain things which we will, and the post-operative edema, increase the discomfort. All these are certain challenges thrown on our face intraoperatively or post-operatively, and we would have not expected it. But if we done our investigations correctly, we would have expected it and probably counter-attacked this particular challenge beforehand itself. Sometimes within our hands, sometimes we would have made the patient understand that this is what is going to happen. So please be mentally prepared. So very important. BTCT, PTT, and APTT. Very important. You are doing an invasive procedure. You may not give an incision, but you're making a hole. You're going to extract a tooth. if you're going to place implants. So invasive, bleeding is going to occur. Very important for us to understand. So bleeding time is a measure of how long it takes for a small skin to stop bleeding, which reflects on the patient's platelet function. And in the previous slide, we have already understand the platelets is already checked in the CBC. The bleeding time will help us to understand how the platelet function is. Along with bleeding, always the clotting time also is checked, which is nothing but that particular bleed is taken into a capillary and how much time is taken for that bleed to really that blood for a clot is checked in the clotting, because that will reflect the clotting mechanism of the or the clotting cascade. Now, prolonged bleeding time will indicate the platelet disorder, whereas prolonged clotting time will indicate problem with the blood clotting factors. And we all know patients will have heart issues, will have cholesterol levels, will have, and they'll be taking blood thinners. Today, it's become such a norm that medical practitioners have started prescribing very low dose blood thinners to to asymptomatic individuals beyond the age of 40 as a preventive measure to prevent any untoward cardiovascular problems in a later stage of life. Now it has become a practically norm to provide these medications post 40 years to reduce blood pressure, irrespective of the patient is symptomatic or not. So it is all the more important because we would be trying to understand why this area is bleeding or what has gone wrong. And if we had not known, we would have not been prepared for it. Now the point comes in is if BTCT is what we think, what is PTT and APTT? This PT prothrombin time and the APTT are purely associated with the clotting cascade. That means it helps us to understand the clotting time correctly. So an impaired clotting time would be there's something wrong with the clotting factors. So PT, that is prothrombin time, will focus on the extrinsic pathway. So it will basically find out if there is any problem with the factor 7. Whereas the factor 10, 12, 9, 8, all these factors which are there helps us to understand via the APTT, which is basically the intrinsic pathway. So by understanding this, we know exactly if a clotting time is prolonged and there's some problem with the clotting, what could be the problem associated, intrinsic or extrinsic. This PT and APTT will help us to understand. So bleeding time and clotting time is a must. In fact, sometimes with this bleeding time and clotting time and APT, the doctors, the technicians say, sir, why you're asking for bleeding time, sir, clotting time? Why don't you just directly go for PTA? Because APTT and TT are costlier investigations as compared to BTCT. But we have to understand, we are not here to hematologically solve the problem for the patient. We are here to make sure that to check whether something is wrong or not, because it should not interfere in our work of or in our procedural time. So BTCT is what we order, and if we see that there's an abnormal CT, then that is clotting time, then we do a PT and APT. But if you want, it can also go on in one go itself. You can order. That's up to you. The next comes in is diabetes type 1 and type 2. And some patients will say, yes, I am diabetic, but I'm under control. Some patients will say, I haven't checked, but I am not diabetic because I don't have any features, but not realizing that diabetes is a very chronic. Yeah. I myself, I was surprised when I did my blood test last year. I realized that I'm pre-diabetic. Not that I have any problems. Life is going on. I'm eating good amount of sweets. I'm practically eating a lot of sweets, I think. And thinking that life is normal, but not realizing that I'm already a pre-diabetic at the age of 37. So we don't know. So patient walks in and says, I'm not diabetic. Please do not go take it as a gospel the truth. Make sure you check for certain investigation. That would be the best investigation is glycated hemoglobin count A1C test or HbA1c test. because it measures the average blood sugar levels over the past 2 to 3 months. It is not that one day. It is like a past through 3 months. So what it basically does, it'll measure the percentage of the RBC cells coated with sugar. So that will help us to understand खून मीठा है या नहीं. So normal blood sugars would HbA1 levels are always below 5.7 and is considered normal. Pre-diabetic ones are 5.7 onwards to 6.4, meaning that they have a higher risk of developing diabetes. They are at the borderline. Now, diabetic patients will have HB1AC levels above 6.5. But to understand during the procedure time, whether the patients have a high blood sugar levels or low, your fasting blood sugar, your random blood sugar, and your postprandial blood sugars will help us to understand the level of fluctuations, how they're fluctuating, and whether we should go ahead and do a procedure or not. Pre-diabetic patients and normal blood glucose level patients, no issues, we can go ahead and do our procedures. But diabetic patients which have the HB1AC levels beyond 7, we should be very careful and selective in deciding whether we want to operate or not to operate, because trust me, patients with uncontrolled diabetes and patients with high blood sugar levels are prone to post-operative infections, are prone to post-operative complications, and also are more susceptible to failure as compared to same age, same sex patient without diabetes. So it is very important and critical for us to take this particular test for every patient. I practically feel BT, CT, and HbA1c are very important and a must in our day-to-day practice. Other than one of the important ones which we need to understand is HIV and HBsAg. Now, there is a lot of a debate that goes on regarding HIV and HBsAg prescribing a test for this. The debate says that there is a one sect of medical practitioners say that it is a very confidential information and it should not be randomly, patients should not be subjected to this particular investigation randomly, and it shouldn't because it should not be made into public domain and all that. There are certain issues associated, but a majority of the chunk of the medical practitioners, including this is everything associated that medical practitioners can do, but dental practitioners should abstain from doing this. But we consider it as a practically a wrong philosophy. We are dealing with blood, we are surgeons, and we are dealing with a patient. And it is our we kind of practice, it's my birthright. It is my right as a surgeon to know if my patient is HIV positive or negative, if my patient is Hep B positive or negative, because these two are very dangerous and very highly volatile and highly infective conditions for a patient, which the patient, it's a chronic, and patient will sometimes may not even know about it for years together and accidentally get diagnosed. We are risking ourselves to work on patients. My mother is a surgeon herself, and she says that whether you do a test or not, please consider every patient as an HIV positive and HBsAg and maintain that personal protection barrier for that, which we will discuss in the future slides. But having said that, we should get an HIV test and HBsAg test, not just from the perspective of our cross-contamination, but also from the purpose of understanding the immune system. Why? First thing is HIV. It's a virus that will attack the immune system of the body. So when it is going to attack the immune system body and we are doing a surgical procedure, then these are the patients, if they're immunocompromised, then they are susceptible to opportunistic infections, which may become life-threatening for themselves itself. And we would have not understood that. Understand, HIV positive patient is different and AIDS patient is different. If a patient is HIV positive, does not mean that we do not treat them, but we take some special care for ourselves and for them so that there should be no cross contamination. At the same time, we need to make sure that we need to keep our procedures as asymptomatic and as low invasive as possible, because these are the patients where the system is compromised, the immune system is compromised, because the virus attacks the human, what do you call, the human immune system. That is why. Hepatitis B, another important virus which affects our blood, and HBsAg is a test. There are many tests for that, but the most important test which we need to just do is to understand whether the patient has got a current infection or not. Though there is no vaccine developed for HIV, but there is vaccine for hepatitis B, which all of us as dentists have taken during our college days, and we continue to take booster doses. But that does not mean that we do not risk to get exposure. So hepatitis B should be made sure that we ourselves, to protect ourselves and to protect the patient from cross-contamination, we should be doing that. And second, because hepatitis affects a virus inside the blood, if it is in a current infective, it is going to attack the liver. And the liver is a place where the entire system gets processed. All the bad things get processed. So a defected liver function test would be the next result of a positive hepatitis B patient. And if the liver has derailed values of bilirubin levels, of other alkaline phosphatase levels, other important aspects of the LFT, that is liver function test, are then our procedures need to be, should take a back seat. We should make sure that they become medically fit from the medical professional perspective. And then we are not here to treat a liver disease. We are not here to treat hepatitis. But we are here to understand that if the patient has this, then it may affect, or it will affect, our final outcome of the surgical outcome. So that the patient should be aware, and we need to get our consents before we go ahead and do it, and not repent later on. So these are the investigations, which is practically every surgical patient, extraction or implant placement, we should get these investigations before we even attempt to do the invasive procedure for the particular case. Other than that, further investigations would be there, but we can then, once we get any type of deranged results in these, the patient can be subjected to higher level of investigation, which doesn't come under our domain of work. We can, send it. We can refer the patient to a medical physician. There is a general physician who will take it on further from there. And once systems are a little more stable, will gives us a consent and gives us a go ahead, and then we can go ahead and do the procedure. So this is about investigations. The next what we will be talking about is the armamentarium or instrumentation. Now, why it is a need? What is the need for us? What is the rationale behind understanding the instrumentation? One is, the instrumentation is what is going to help us in executing the plan, the surgery. So precision and accuracy holds a very important aspect for optimal surgical outcomes, patient safety and comfort, and for maintenance and longevity. A well-selected and properly maintained armamentarium is not merely a collection of tools, but a foundational element that underpins the success and predictability of the dental implant procedures. Beautiful statement by Essential Tools Used in Dental Implant Treatments, November 14, 2004. What a statement. A well-selected and properly maintained armamentarium, it is not just a fancy show of what we have, but it is nothing. It becomes the foundational tool to make our life ergonomic while we are doing the procedure, and to make sure that an uneventful and a smooth and least minimal invasive procedures are done for the placement of the implants and then the post-op rehab of the patient. This is a very good picture. And what is this doing in our program, in our lecture? Now, if you see on this side, you have these Formula One racers. We look at them, the way they drive and the way they do it. But we don't realize that that they're just not taking a wheel in their hand and just driving a simple car. They are driving with fractions of second level of decision making. They have so many instrument buttons and algorithms which are there, which will help them and guide them in the precision fractions level of decision making and movement and maneuvering, making them champions. And if we have to take pictures like this and be champions in our field, we need to know that instrument cluster of our machine F1 car very well. And our F1 car is our instrumentation, that is armamentarium, and our chairs. Then only we can also take and pose. Because trust me, we are nothing less than them. In a human body, even we also have fractions of seconds before we go ahead and take a decision while we are drilling, when we are placement, and we are coming out. So our instrumentation and the know-how of those instrumentation also is very important. So the surgical instrumentation armamentarium, and then there's prosthetic instrumentation armamentarium, including the material science. So we'll talk about the surgical instrumentation. In the surgical instrumentation, we divide it into three parts or three tables. The instrument tray table, which is very close to the surgeon or the operator, the supply tray table, and the implant tray table. Now, implant tray table very well means all the implants which are arranged for that particular case and associated equipment associated with that. Nothing much. What is important to understand, what will be on the supply tray table, which will be kept a little far, a little away, and that will be, as the word supply, it will be supplied to you from your second operator or from your assistant. It is not something which is really important at the time of your procedure. But instrument tray table holds a very important aspect. We'll go one by one in each of them. Now, this is going to, first material which we are going to use is betadine. Now, why did I put betadine? Betadine everyone uses. So what is so great about it? Now, we definitely know it is an antiseptic agent. It's an antimicrobial solution, which with bit. But trust me, I have gone to certain clinics. When I said, give me betadine, they have given me betadine mouthwash to go and scrub. There's a difference between that. We have 10% povidone iodine solution, which is again betadine. But that is solution which is basically used for scrubbing the lower part of the face, the nose, the chin, and in and around to eliminate the dead skin and the bacteria, but externally. Whereas betadine mouthwash is 2% gargle, which is basically used for gargling inside the mouth. We cannot use 2% betadine to clean the external surface. But the subtle differences patient will be, because this is also betadine, that is also betadine. Both are same, no? But patient is asked to rinse the mouth with betadine solution to reduce oral bacterial count, and outside the skin area where we are going to touch with our hands and all, for that we use 10% betadine solution. They are both different. When we want to irrigate the areas of the infection and the abscess, we are going to take the betadine solution, dilute with water, and then going to clean it. We're not going to use a betadine gargle to do that. So subtle differences we need to understand and keep this in our clinic. The next comes is anesthesia. For anesthesia, all of us have these topical aerosols. I really hate them because these surface agents are the first line of giving irritation to the patient. Most of our patients would have seen that as soon as we take this topical and we spray inside the mouth, they would have probably swallowed it, start feeling discomfort because now even the throat is numb. It is a generalized area inside the mouth which gets sprayed with this particular topical. It's very potent, and within immediately you start feeling this kind. It is pungent. It is bitter to taste. I practically avoid using that. But we require to topically anesthetize the area where we are going to insert our needle for injecting the actual local anesthetic solution. So I use gels. So gels are very controlled area. They have different tastes in them. You can use orange taste, you can use strawberry taste and all that. And wherever we are going to apply that particular or we are going to inject, that is the local areas, we can use this gel and nicely rub it so that only the small area gets anesthetized and your mouth doesn't feel numb and irritant for the patient. See, when we are doing a surgical procedure, we need to make sure that Once the patient is anesthetized, whatever surgically do, patient may not know much about it. But if we put the patient into discomfort mode even before the start of the procedure using some of these obnoxious what called stimuluses, we will start losing the confidence of the patient, and the patient will go into a discomfort mode from even before we started the procedures. So giving anesthesia, the way we give anesthesia, the way we apply topical anesthesia holds very much importance, which emphasizing, but practically in our day-to-day practice, when we are doing it, I realize that this makes a lot of difference. Patient comfort preoperatively and intraoperatively are very important for patient to smile and tell you that I am very happy, because that's what the patient is going to go back home with a memory, and that is what is going to motivate the patient either to tell, oh ba, don't get this procedure, man, it is very painful, very headache, or say, oh, it's very nice, very comfortable, doctor is very good, I didn't even feel anything, very nice. The difference between these two is such areas which we have to focus on. So I would advise the use of gels as compared to local sprays, though the sprays are more potent. Now, the second thing is what anesthesia to be used. Now, most of our practices, we buy that 54 rupees lidocaine bottles. We use our 2 ml syringes. We aspirate, we go ahead and we place. Very painful for a patient, because the gauge of the needle is such that it is thick and you're piercing it intraorally. Extraorally on the skin itself is painful. Intraorally, it is more. And when we deposit, the flow of the Alamid, that particular book, it mentions that 1 ml over a period of 1 minute we have to inject. Trust me, how many of us are really doing that? We use that, aspirate, and immediately inject. While we are injecting the anesthetic material into the soft tissue, we are causing we are basically causing a dissection of the periosteum and the soft tissue over there. So when we are going ahead and injecting the local anesthetic, we need to be very careful the amount of anesthesia injected and at what force it is injected, what is the gauge of the needle we are using, plus what is the material of choice, whether it's short acting or it's a long acting. Now, lidocaine is practically medical anesthesia. It is not dental anesthesia, and I am being very candid about it. For dentists, it is articaine which has been developed over a period of time for us to use. So we should be using articaine as the long-acting articaine as the material of choice, or the or the medicine of choice for local anesthetic as compared to lidocaine. Why? There are reasons for it. As compared to lidocaine, the articaine has a rapid onset and has an intermediate duration as compared to lidocaine, which has a short duration. It has better penetration into the tissues and has more usage as compared to lidocaine. Now, lidocaine cannot really anesthetize a hot tooth, but articaine, once injected into the pulp chamber, once injected in intraligmentary, will give beautiful results. Now, for 10 years of my life, I was using lidocaine. So in the past 5 years, I have started and I have shifted towards articaine, and I've realized that how beautiful and how good and effective it is. Because when I'm injecting articaine, the gauge of the needles are very thin. Patient don't even know that I have already injected articaine. It's a very controlled mechanism in which you inject. A very calculated, every cartridge has a calculated 1.8 ml which is present in it. So overdose is not happening. Plus, as the reach is good and the penetration capacity within the cells and the tissue is so nice, which makes the articaine more effective. And just don't believe my statement. Just don't believe my statement. I'm really telling you, don't believe me. Use it and then you'll understand. And before using anything, you need to have research to back you up, right? I will show you research of what articaine is any day better than lidocaine. A comparative study of the efficacy between articaine and lignocaine in a simultaneous bilateral orthodontic maxillary premolar extraction. That means it's the same patient. One side articaine is used, one side lidocaine is used. What are the results? When compared, the articaine group had a longer duration, that is 217 minutes, as compared to lignocaine group, which is 169 minutes. They had greater pain reduction with the Articaine group and exhibited less issues. So the conclusion in this particular article mentions, which has been in the PubMed journal, that when a split mouth comparative study was done in the same patient, Articaine was more effective local anesthetic as compared to lidocaine. And that's what we want. We want longer duration, comfort for the patient. So when we are giving anesthesia, the patient is comfortable, does not react, has no reaction. So the patient becomes more cooperative for us while we are doing that extensive cortico-basal implant procedures, when we are going in and out with our drills. The whole idea of developing of when you compare cortical basal with conventional is the ease in which we are doing it, the less invasiveness of that particular thing, less drilling inside the bone, and making sure that we are more ergonomic and immediate loading. So out of all the aspects of cortico-basal where immediate loading is given a lot of preference, even these things are all important. And one of the aspects is use of Articaine. Another article which mentions, which is a meta-analysis, the BARP of articles mentioned in the Journal of Dentistry in 2009, which mentions the efficacy and safety of Articaine versus lignocaine in dental treatments. The conclusive results say that in a systemic review, it was very much seen that Articaine is more effective than lignocaine in providing anesthetic success as compared. And Articaine is a superior anesthetic agent to lignocaine for the use of routine dental procedures, statement given. That's how beautiful and that's how aggressive it is. Another article which mentions Articaine in dentistry overview, and again a meta-analysis mentioned in the British dental journals. It also mentions very clearly that Articaine has a higher likelihood of achieving anesthetic success as compared to lidocaine. And it is more safe and more effective than any other material. Coming on to how Articaine would be used. For Articaine, we require a dental aspirating syringe, which is reusable. So one syringe, which we're going to keep sterilizing and reusing. So we don't have to keep on buying boxes of those 2 ml syringes. This is more than enough. We have proper disposable needles with a specific gauge. And then we have cartridges. Now, these dental aspirating syringes have their part, the threaded tip, the harpoon and all. We insert the we insert the cartridge inside the harpoon area, that is the piston rod area, in the barrel area of the syringe, and then we attach at the knob, the threaded tip area, we attach the syringe, and then we aspirate and we inject in a controlled manner. Next part is the personal protection barriers. Nothing but your disposable gowns, your head cap, your mouth mask. I don't have to go and stress much into it because we know how important personal protection barrier is. After COVID-19, all the more we have become aware of cross contaminations, and these should be disposable in nature for doing it. But the use of gloves should be focused on not disposable gloves, not disposable diagnostic gloves, but disposable surgical rubber gloves for doing it, because they are puncture resistant and they are sulfate free. So making sure that we do not contaminate as they are sterile in nature. The word is sterile. We don't want to give infection to our patients. The surgical table should aim at keeping the surgical field relatively sterile, should be in closer vicinity to the operator, and should be arranged in a systematic order to allow easy picking. So your assistant, when they will set up the table, what we require is not what is shown over here in this particular Soden picture, where it is showing so many complicated instruments. This is all basically when we are going ahead and doing a conventional thing. What we require is very simple, but that also should contain, but we should have at least a basic extraction setup, which is nothing but a periosteal elevator. We should have some curettes. We should have a needle holder, surgical what do you call blade holder, A retraction forceps should be there because sometimes while after extraction, we may end up in open extractions and we may have to suture those areas sometimes, but most of times may not require. So what would be a basic setup would be mouth mirror probes and tweezers. And of course, we also should also have tissue forceps, beaked tissue forceps. We should have our instruments in terms of our hand ratchets and machine ratchets, our burrs, our syringes. I've specifically mentioned over here is lidocaine with which is on the 2 ml syringes, because over there I showed you on the other slide I showed you articaine. So over here, what usually everyone uses is this lidocaine, so that your extraction forceps and your micromotor with the sprays and other parts. So this is how a basic setup is what is required when you are doing corticoids. Very simple, nothing more. But sometimes you need to keep a set of these instruments for with you, that is scissors, your needle holders, because you may end up with some open extractions for the patient. So just for as a extra standby instruments to be kept, nothing more than that. On your supply tray, we require is intraoral mirrors, cheek retractors. I love these metal cheek retractors which are present over here in this slide. I love these ones because they really help in proper retraction as compared to the plastic ones, and they are very we can really make them sterile by getting them into an autoclave as compared to these ones. These are not autoclavable, so we have to use cold sterilization. But these are good enough for only photography purpose. Chlorhexidine, normal saline, which is going to be added to your fissure dispenser. We need 3O sutures or 4O vicryl reverse cutting sutures should be present with us. Other than that, some cotton holding forceps, your photo camera, and protective eye gear. These all should be in supply chain, kept a little far away, not anywhere close, not much close, because you need space in and around the surgical area. In terms of instruments, in terms of equipment, what we require is a fissure dispenser and not a micromotor. Why a dispenser? Is because of the fact that a fissure dispenser will control the speed, the torque, and the power of the drills which you are using with the help of specialized gearboxes inside. It will reduce the damage to the bone while surgically placing the implants. And it has an integrated cooling system which will push in normal saline while we are doing it, which with your hand you cannot really achieve, because the direction of the flow of that particular saline is controlled and is exactly directed towards the blade edges, so that we get proper external irrigation while doing the osteotomies. And fissure dispenser comes with various program and gear ratio, that is 20:1, 16:1, 1:1. We need to use the 1:1 program inbuilt inside the fissure dispenser while doing the particular thing. Now, this is a fixed cortex basic level of a fissure dispenser, which has 1:1 system control. And the range is from 20 to 40,000 RPM, and a torque will range from 50 to 70 thing. It also has gear, but 1:1 gear ratio is used in cortico-basal implants. One of the best systems in the market which are available is from the NSK, and from the other one is from WNH. These are the two gold standards in fissure dispenser, but they are costly. They are anywhere between ranging from 1.5 lakhs to 2.5 lakhs, including a 20:1 gear ratio handpiece. But we need to buy a 1:1 gear ratio handpiece for us. And when I'm talking about 20:1 and 1:1, we need to understand what this is. So basically, all this is nothing but the ratio of the torque and the speeds. So 1:5 means that when one gear is present, it is 5 times enhancing the speed. We are using them for cavity cutting in our aerotors. 1:1 is whatever is the input gear provided, the output gear is the same. That is, it maintains a good high speed, but does not really focus on the torque. And this 1:1 is what is used in basically in basal implantology, so as to achieve quick bone cutting up to the second cortical, because we go deep in one with the lancet drill and out. We do not go to enhance the osteotomy, and we need a very quick system as compared to conventional methods where we don't go beyond 1200 RPM and 35 newtons of field. We don't want that because we prevent excessive heat generation near the second cortex area. So 1:1 is what is important for us as compared to 20:1. Now, surgical handpieces, we require what we call as the contra-angle handpiece and the straight handpiece. WNH gives a very good, yeah, other than Marathon company, WNH is a very good company which provides us these. Yeah, we should mention surgical handpieces in 1:1 because the regular handpieces have up to 20,000 RPM. The surgical ones have got up to 40,000 RPM. Which we have to use, and we are using 40,000 RPM only speed to go ahead and make the drills. We all know that. So WNH is a very good company to be used other than Marathon. We also need this contra-angle because in your lower anteriors, that is mandibular anteriors, and certain inaccessible areas, the contra-angle really helps in. But the ratio just 20% of the times we require it, but 80 to 90% of times your straight handpiece only does all the job beautifully. Okay, so always keep 2 sets of straight handpieces, one contra-angle handpiece, and at least 2 straight surgical handpiece you should always maintain in your library when you're doing along with intro. Yeah. Coming on to the implant kit includes 4 main components: the surgical rigs, short and long, the ratchet drivers, the ratchet, and the handles. So this is a fixed cortex surgical kit. In that you have the ratchet, uh, uh, holder, then you have short drills and long drills. Now, all these short drills and long drills have certain diameters. The pink one is a 2 mm diameter. The blue one is a 2.5 mm diameter, and the red one is a 3 mm diameter. The red ones are short and long. They are basically used for pushing in your stabilizing implants, not your strategic implants. Whereas the 2 mm is used for the 3.5 diameter implants, and the 2.5 mm it can be used for your 4 mm and 4.5 mm diameter implants to be inserted. So you can see here, one short, one long, they do the same purpose. Then you have 2.5, which is again the same purpose. So that's how the color coding is there. Practically, the color coding cannot be considered universal. It is from the company perspective. So different color codings for different, but all companies of cortico-basal come with basically lance drills. No other different types of drills are basically there to confuse you. And these are and where you have a short area, we are using the short lance. When we are doing pterygoids and doing posterior, when we are doing anterior mandible and all, we are using these long drills because we have to go very deep inside, depending upon the length or how far the second cortex is from the crest of the ledge. So lance drills, they're highly polished and have laser markings. Drills are available in 2 lengths, small and long, as I already mentioned, 2, 2.5, 3, and 3.5. Most commonly used drill is the 2 mm. I actually have at least 4 or 5 sets of these drills. And trust me, and one thing is important is you can't use these drills for more than, let's say, 10 to 15 osteotomy, max 20 osteotomies you can do. After that, please, otherwise they may break inside the bone because they get drilled. They're very sharp and their job is to cut through, pierce in and come out. So their utilization is high, heavy activity is there, and they're very thin. They may fracture inside the patient's mouth and very difficult to retrieve that. So be very calculative about the number of times you have used it. When you start seeing that, black soot is coming up, or we are seeing burning smell coming on the bone, and we see that they become blunt, immediately discard them and pick up new ones. Not more than 1,200 to 1,500 rupees is the cost of one drill. So make sure you do that. Otherwise, once they break, it becomes very difficult. Short drills are used for placing wide body and compressive implants in the mandible and maxilla. And in the mandible, the mouth opening is less. So if the bone is very dense, sometimes 2.5 and 3 mm can also be used. So here I mentioned, see, lance drill should be changed after 50. I practically keep up to 20 to 25 osteotomies is what you should use. I would say that if you're doing a full mouth surgery, once you do that particular surgery, discard that particular drill. Don't use it for the next surgery. Not more than 1.5 full mouths. That's it. 2 or 3 arches. That's it. After that, please discard it. Don't use it because of wear and tear is very high. Then is ratchet drivers. So what is the job of these ratchet drivers, both long and short? Is that these ratchet drivers will help in not only giving a torque and inserting the implants in inaccessible regions with the help of the ratchet, which is the ratchet driver, as you see over here in the photograph. They also help in bending the implants when to bring them into perfect alignment after the putting them. Now, In our cases, when we usually use a hand driver, engage the abutment of the implant into the hand driver and insert it and torque it inside. Sometimes we use the ratchet drivers also do that, especially in the posterior mandible. We can use your hand driver itself to do the bending, but ratchet drivers are more controlled method of bending as compared to the hand drivers. Okay, so that is what is these two hand drivers. Okay, but 90% of the times it's the hand driver which comes into handy for us while we are torquing the implants inside the particular bone. It's very ergonomic and very comfortable. There are different types of tips designs which are present. Now, if you see over here in the photograph, you have the short diameter, you have the broad diameter. Those tips are different. And there's the same handles in fixed cortex. We have kept them as a normal abutment handle because our abutments across all types of implants, whether it's a 3.5 implant, whether it's a 4, 4.5, 5, whatever may be the implant, all of them have the same abutment size. So only one handle is what we use in fixed cortex when we are doing it. Okay. Now ratchet is used to basically as over drivers to tighten the implant. They provide infinity torque and they help us to even do achieve primary stability and bend the implants. Other than this, we require a sync crystallizer, which is an intraoral welded. We purely believe in the concept that BCS implants, bicortical fixed implants, should be intraorally welded as a method of rigid fixation as compared to use of metallic bars. Another topic to be discussed on a different day, which one of my colleagues, Dr. I think Priyank, will take it. But sync crystallizer is a very important instrument which it should be present at the time of surgery because sync crystallization is done immediately after surgery. After bending the implants, bring them parallel to each other, we go ahead and use 1.5 titanium wires to join them and intraorally weld the thing and use a sync crystallizer double time for each arch. So synchronizer machine is what this fixed cortex is, the basic level of synchronizer which we use. I have put this particular surgical section machine as an extra in thing is because I truly believe, and this is out of experience with most of you would agree to me, is that most of our procedures are invasive. There's a lot of blood which is involved, a lot of saliva, blood, the thing is there. Our regular suction machines, which are a part of the chairs, are not really equipped to handle that level of suction systems. So this simple 6 to 7,000 rupees machine, very good efficient method of using suction inside the patient's mouth, especially for surgery purpose. So in my clinic, I have bought this and kept this, and this is what we use for every surgical case. We don't put load on our costly instruments which have a light work. It's something like we don't use a car parked us for doing work of a tractor. This is like a tractor in suction. This is a very hardcore machine, very cost effective, 7,000, and this machine would do the entire suctioning process for long durations as compared to the one which is chair side, which usually suddenly in the middle will get switched off or get blocked because it is used for only simple works. Little bit of saliva and not more than 10-15 minutes. These can be used for hours together in the particular system. So we're coming to the prosthetic armamentarium. Impression materials, we all know alginate and putty is the impression material of choice. You should keep it. Other than that, materials like basically for making the models, we require dental stone, dye stone, cold cure resin, and pattern resin. Intraoral scanners, it's an optional machine, but nowadays almost everyone is maintaining this intraoral scanners in our clinics for our day-to-day purpose. So yes, intraoral scanners also is an equipment which should be kept for doing a post-operative recording of the oral cavities rather than using impression materials. It's cost effective. All that is there. I'm not going detail, but yeah, today's world, even intraoral scanners use. For cementation and for luting materials, GIC and hardliners are used. Other materials include the 1.5 titanium wire, as you see in the picture, a carbide burr because we need to trim, we can't use those diamond points to trim and adjust the abutments intraorally. These carbide burrs from Tri-Hawk, which is specially Talon 12 cusp things, are the ones which should be used, very effective. And to do that, instead of using a regular aerator, which is not so efficient in cutting metal. An electric motor would be really efficient. It's anywhere between 20,000 to 30,000 is the cost of the electric motor. Can be easily attached to the to our existing chairs, and with water flow and with light, and they effectively cut, because here it's not an air rotor. Air is not used here. Electric thing is used to run the carbine machine inside to bring about the effective cutting of that. So it makes the system more ergonomic, less time consuming. Thereby, it reduces the chair side time for the patient, both during surgical procedures as well as during the prosthetic time. At the end of the day, what we want is this: two people doing the same job, one doing more ergonomic, will have a better result as compared to one taking a lot of time for doing that. Other than that, the most important aspect, which is the implant, which should have at least a stock of 50 to 60 implants when we are doing even a quadrant case. When you're doing full mouth cases, minimum of 60 to 70 implants should be present, because when we are dealing with cortical bone, when we are placing, how much ever we use the CBCT to measure and all, but at the time of surgery, the decision making of which implant to place and what size and what length is at the time when we enter into the osteotomy, and we know at what point we felt the depth. At that point, that particular level of 2 mm short of that particular distance is what we pick up the implant and use. The implant has three parts, which is nothing but your smooth, your abutment part, your shaft, and then the thread part, which is going to engage the second cortex. Okay. So this is when we uh, do extractions, and we do with extractions when we are doing placements in conventional implants, where we need blades and periosteal elevators, and we need needle holders and all. We need conventional kits like this. But when it comes to cortical implants, we need very simple kit, a couple, just one or two drills, which are basically used in a very simple system to be done. And what we require is nothing but a hand ratchet, a machine ratchet, and yeah, so you don't see much about of invasive blades and things kept over here and sutures and all. But sometimes we need to keep it in the back end, because we may end up doing some open extractions and where we need to use those particular systems. Thank you very much for joining us on a Sunday afternoon and giving your valuable time. That ends our presentation. Dr. Ashish?
Yes, sir.
The presentation हो चुका है, तो any questions to be for that? Anyone, any questions are there? Any questions? I think we can close it. Arya?
Sure, sir. Thank you so much, sir. It was a great session.
Okay.